we will allow. Security connectivity was a big consideration during our project, particularly in relation to working offline with patient-identifiable data. All the devices are encrypted using McAfee encryption, and we further improved our security using a product called CompuTrace, which offers us remote data deletion and hardware theft recovery should any of the devices go missing. As Tracy mentioned earlier in her piece, mobile signal is our biggest problem in Cornwall. We've overcome this to a certain degree by using a thing called an Abaca SIM card. Abaca are a Scottish-based airtime reseller, and their bundled solution allows you to choose the best signal from 3UK, Orange or O2, depending on which is available at the time. In certain areas around Cornwall, we've also had to implement Vodafone SIMs because obviously the connection is so much better in various parts. So I think the important thing is you need to make sure you do a full map of your area and see where the best coverage is for each card.
So this is the Spot the Difference competition. The earlier slide I gave you, the spaghetti slide. So is there a difference then? Come on. Don't be shy. Shall I tell you what the difference is? Okay. The map of travel is hopefully much more streamlined. The boxed area represents those places that can now be accessed virtually by the use of with our mobile technology. Usually, staff would normally have to at least make a phone call to these places, always engaged. You need that information there and then, or visit them. They no longer have to do that. So in actual fact, it creates the opportunity for either more visits or better quality visits. And in actual fact, there are 2 extra houses, properties on this map. So, the benefits then. Improving patient safety and quality is achieved by reducing error risk and improving overall governance. The information sharing and reduced duplication, this is achieved by the Common Assessment Framework and the virtual access to other patient-held data systems. Greater patient continuity and a more efficient service delivery by having that information that is up to date, multidisciplinary, available at your fingertips electronically. That's how that's achieved. The time and mileage savings, well, hopefully the previous slides have demonstrated that, and the maps have hopefully shown that that's what can be achieved. Patients feel more in control of their care with an improved experience, and that's because these new processes are very much patient-centric. I wanted to share this quote with you. This was Sarah, the occupational therapist you saw earlier. She'd had her tough book about a month when she emailed this to me, and she was more than happy for me to share it with you, just to demonstrate how effective it can be.
So, to conclude, it's only the beginning of our mission. We'll continue to improve the patient experience and quality by having information available at the point of care. We will continue to evidence benefits and continue to increase capacity and realise efficiencies to support the QUIP agenda. Our carbon footprint should also continue to improve, which is clearly important in Cornwall with it being such a rural county. We will continue to reduce system waste, become paper light, and make community health services a more IT efficient organisation. We'll continue to implement shared electronic records across health and social care, regardless of organisational boundaries, and information will be available at the point of care. If it can work in Cornwall, it can work anywhere. Any questions?
Yeah, I think that still happens. I think there's always going to be times when you have to meet as a team, but I think the difference is that a lot of time is saved by not having to continually go in, because, you know, as a clinician working in the community for 25 years, I know the time I must have wasted going in, going back. You go to a patient, you forget something, you want a result of some sort, you need to talk to somebody. You can do a lot of that virtually now. I don't think you lose that team cohesiveness because you still have to meet as team members, but it just means that the actual time wasted is saved.
Have you had to encourage the clinicians, if you like, who are quite happy to just work on their own?
But I think the average, we did a bit of a anecdotal check, didn't we? And 15 minutes you can save probably every half of a day or whatever. So, you know, that's time that you can spend with your team. I think for district nursing, there's never a problem getting them to work as teams. I think for the lone workers, so the community rehab teams, the community matrons, who are very much used to working autonomously anyway, it's not an issue for them at all. They do still go into the surgery because you have to, because you've still got to talk to everybody. But so I don't think it's forcing people to work alone. I think it just saves... I can't hear you very well, but it was around... District nurses use the single assessment process all the time. A lot of our other clinicians don't, though. District nursing patients always have a patient-held record in the house. Some of our other services, they don't. So they've probably got a personalised care plan in the house, but they don't have any other records. What we've said is that obviously for the people we're sharing that assessment process with, it's very easy, because if you've got electronic devices, then that's not a problem. But for those that haven't, we've said to them if they feel that they want to print a copy out, but again, it sort of contradicts what you're trying to do, then that's okay. But what they have to ensure then is that they update that assessment and make sure that whatever's being updated electronically is reproduced in the house. The system we're using for the shared assessments, there's a very basic first assessment with all demographic data, all the stuff that patients will have been asked over and over and over and over again. Now, you're only going to ask that once, and that's probably not going to change on a regular basis. So we leave that with the patient if that's what they want. The other assessments obviously are shared electronically, but there is the option to print out, do you wish to? But of course that is an issue, how you maintain that up-to-date record. But it isn't a patient-held record, I must stress that. It's an shared assessment process.
Not yet. No, even this one will work if you want me to turn it on and assess it. No, we've got a pretty good in-house IT team which has helped us along with this project. So we haven't actually bought any outside help. Although I would say that in the project phases, especially, the help that we have received from Tracline has been, it's brought expertise to the team that we didn't have. But that's been on a kind of informal basis around project meetings.
Thank you.